Hey team, my name is Jeremy Seitz. I'm a third year Peds ICU fellow here at UNC, and welcome to my fellowship project. In this video, we're going to be talking about congenital heart disease, specifically two topics, Tetralogy of Flow and ductal dependent lesions. But sort of the broader 10,000 foot overview of my project is that I'm looking at comparing in-person learners to asynchronous learners, and asynchronous learning means learning from home, using pre-recorded materials, at a time of the learner's own choosing. And so, using this congenital heart lecture, pre and post confidence and knowledge assessment surveys, as well as simulation performance evaluations. The simulations will happen in November, and here shortly I'll reach out to you guys to schedule those. And so that's sort of the basis of the project, comparing in-person learners to asynchronous learners. But for now, let's get into the video, the topic of the discussion, as I mentioned, congenital heart disease, Tetralogy of Flow, and ductal dependent lesions. Hope you guys enjoy. By now you should have received an email with a link that will take you to a Google form, two Google forms in fact. The first one will be the pre-knowledge assessment, and then the second one will be the pre-confidence survey. So if you can fill those out for me. To make it a little easier, I've also included a QR code here in the next two slides. So if the email didn't work or you were unable to do it, go ahead and pause the video now. Scan this with your smartphone, and it should take you to the assessments, and you can fill those out. It should take you less than 5 minutes to do. So feel free to pause the video and fill those out if you haven't done so already. Otherwise, you can continue on. Now that we've done our introductions and you guys have filled out the pre-knowledge assessment and pre-confidence surveys, let's jump into it. This is mini talk number 1, Tetralogy of Flow. So let's start the lecture off with a case. A 3-month-old previously healthy male admitted to your Gen Peds inpatient service for further workup following a cyanotic spell at home. The parents state he was feeding from the bottle when he developed respiratory distress and blue-gray skin discoloration affecting the face and the trunk. The spell had resolved upon arrival to the ED, but an O2 sat obtained revealed saturations of 85%, despite the infant being calm and comfortable. The remainder of his vitals are within normal limits, and your team has ordered an echo. So question number 1 here, what is the leading diagnosis? I've already sort of given this away and telling you that the talk is about Tetralogy of Flow, but hopefully based on the clinical vignette, you were able to come to the conclusion on your own that this is very likely a cyanotic congenital heart condition. And so if we recall the 5 T's of cyanotic congenital heart lesions, easy way to remember that is by counting to 5. Number 1 would be truncus arteriosus. Number 2 would be transposition of the great vessels. Number 3 would be tricuspid atresia. Number 4 would be Tetralogy of Flow. And then number 5 would be TAPVR, TAPVR having 5 letters. And why Tetralogy of Flow over the other 4? This is a 3-month-old, and the other 4 will typically present in the neonatal period. Indeed, usually the first day to 48, 72 hours of life. And so Tetralogy of Flow, which is a bit of a spectrum of lesion here, which we'll talk about in a couple of slides. Tetralogy of Flow really would be the only one that would escape the neonatal period without clinical manifestation. Question number 2, what might you expect to find on physical exam? The big thing here is just a very harsh systolic murmur, probably grade 3 to grade 5, something very, very obvious. And indeed, for the children that are not picked up, with fetal echo, who leave the newborn nursery without any sort of cyanosis or TET spell that helps the team cinch the diagnosis. A common way these children are picked up is their pediatrician listens to them and hears a very loud, harsh murmur and then sends them to cardiology for further workup. The other subset would be like this child who starts to develop TET spells as this RV outflow tract obstruction gets worse and worse over time. And we'll talk about that in just a moment. But anyway, back to physical exam. The key thing here is just the cardiac auscultation and noting a very harsh, loud systolic murmur. Number 3, what findings would you expect to see on echo? This one is just me trying to get you to think about what 4 features, what 4 anomalies you see in Tetralogy of Flow. So 4 things to remember. Number 1, and easiest to remember, is the very large VSD. Number 2, overriding aorta. Number 3, RV outflow tract obstruction, or synonymous. You may hear people say pulmonic stenosis, synonymous terms. And then number 4 is RV hypertrophy. And so those would be the things that you would expect to find on echocardiogram. And then finally, number 4, what findings would you expect to see on a chest x-ray and an EKG? Chest x-ray, this one's important for your boards, so take note of this, is the boot-shaped heart. We'll see that in the next slide. And then EKG findings, it's really non-specific for congenital heart disease, but it may clue you in. And so in Tetralogy of Flow, you're very likely to see RV hypertrophy, right axis deviation, and then you may even see right atrial enlargement as well. And we'll look at an EKG on the next slide. So as promised, here's the chest x-ray and EKG of a child with Tetralogy of Flow. The chest x-ray here on the left very clearly shows the classic boot-shaped heart that is a result of RV hypertrophy, which we'll talk about again in the next slide. That one's pretty obvious. I'm not one that really usually sees what the radiologist is claiming when they describe a picture within a radiograph, but I see this one, the boot-shaped heart. So important for you to remember that for your boards. And then next on the right side is the EKG, very clearly demonstrating right axis deviation. You have the down sloping of the QRS and lead 1, upslope of the QRS in 2, 3, and AVF, so consistent with right axis deviation. You see evidence of RV hypertrophy in leads V2 and V3. What you may see, and what I don't think that we see in this EKG, I'm certainly no EKG expert, but what you may see is right atrial enlargement, and that's usually evidenced by exaggerated tall P waves in lead V1 and V2, sometimes biphasic P waves as well, and in those right-sided leads V1 and V2. I don't think we see those here though. So you can hear me explain and talk through Tetralogy of Flow all day, but probably what's going to be more helpful is to see it in a picture. So I've included a cartoon depiction of tetralogy here, including all 4 of the anomalies associated with tetralogy. Embryologically, if you think about how this develops in utero, really you don't even need to memorize the 4 components of tetralogy, because the embryologic abnormality that takes place really explains all 4 of the defects. So what happens in Tetralogy of Flow is the conal septum, or that portion of the septum, of the ventricular septum closest to the mitral and tricuspid valves, the northernmost part of the septum, if you want to think about it that way, it shifts into the right ventricle and creates asymmetry. And that shift ultimately will lead to a VSD, that leads to an overriding aorta, it leads to right ventricular outflow tract obstruction, and then, of course, RV outflow tract obstruction ultimately leads to RV hypertrophy. So really, if you just remember the conal septum and deviation into the right ventricle, you can easily remember the other 4 components of Tetralogy of Flow. So Tetralogy of Flow as a spectrum, as we talked about in the last slide, the deviation of the conal septum into the RV is going to dictate the severity of tetralogy. That can be mild, moderate, severe. The mild form of tetralogy will act, that child will act much like one with a VSD, because the RV outflow tract obstruction is present but not severe. So there's still somewhat adequate pulmonary blood flow across the pulmonary valve into the pulmonary artery. And so the child with a VSD will typically present 2 to 4 months of life. They're not particularly cyanotic. A lot of times they have normal sats, again, because they have adequate pulmonary blood flow to maintain normal sats. But how they will generally present as signs of congestive heart failure. So classic things in the infant would be difficulty feeding, dyspnea with feeding, diaphoresis with feeding, poor weight gain, cough on auscultation, probably hearing crackles and then witnessing them breathe. You may see, increased work of breathing and retraction. So all of those things that we think of with congestive heart failure. These are the variety of TET babies that are known as, quote, peak TETs. On the moderate scale would be like the one presented in the clinical vignette from the first slide. That's the classic one. If you remember none of the others from this lecture, remember the classic moderate TET, because that's what you'll be tested on board exams and such. And that's the baby that oftentimes is picked up in utero. Thankfully, we have good fetal imaging these days that will pick these up. But sometimes they make it out of the womb, and sometimes out of even the newborn nursery without a diagnosis. A lot of times they're picked up by their PCP for a harsh murmur that sends them to the cardiologist's office for an echo where this is found. And then occasionally they're picked up when they start having those classic TET spells, those cyanotic spells associated with stress and agitation. And again, moderate degree of RV outflow tract obstruction related to deviation of the conal septum into the RV. And then finally, the severe form of TET. This is the TET baby that probably won't make it out of the neonatal period without the diagnosis, because the degree of RV outflow tract obstruction is so severe that they have either critical pulmonic stenosis or even maybe pulmonary atresia. And so severely limited, inadequate, perhaps even absent pulmonary blood flow unless there's a ductus to supply that pulmonary blood flow. So these babies will present usually within the first 1 to 3 days of life, if not immediately after birth and at the time the ductus closes. And they'll be profoundly cyanotic. They'll require prostin in order to survive until they can get a surgery or catheterization procedure to help augment their pulmonary blood flow. So 3 kind of forms of tetralogy, 3 phenotypes of tetralogy, and remember embryologically, if you can think about how the conal septum plays a role in RV outflow tract obstruction, it'll help you understand the different spectrum that Tetralogy of Flow can present as. Well, now that we've learned all about Tetralogy of Flow, the 4 anomalies associated with it, its embryological origins, and how it manifests on a spectrum of different phenotypes, let's talk about the management for reversing a TET spell. TET spells typically being in that moderate phenotype that we talked about. What sort of therapies do we have at our disposal? Rather than memorize a list of interventions, I think it's more helpful to understand the mechanism of action of what you're doing, and knowing that will help you remember this in the moment when you're presented with this child who's having a TET spell right before your eyes. So what's the first and easiest thing that you can try? Knees to chest for the infant, or if you happen to have a toddler, generally these children aren't living into toddler years anymore without some sort of intervention, but perhaps they're a refugee or an immigrant from another country and they haven't had their repair yet, and they're in their toddler years. So the toddler, you can have them squat. So infant, knees to chest, toddler, squatting position. And what that's doing is promoting increased systemic vascular resistance. So raising the pressure in that systemic circuit. Blood wants to flow from the pathway of higher pressure to the pathway of lower pressure. So if you can increase the pressure of the systemic circuit to be greater than that of the pulmonary circuit or the RV outflow tract gradient, you're going to shunt blood left to right, LV to RV, and then across the pulmonary valve into the pulmonary artery. What's another very basic step that you can do? You can apply supplemental oxygen via low-flow nasal cannula, or perhaps face mask, whatever you have at your disposal. And what will that do? Well, oxygen, remember, is a potent pulmonary vasodilator, and so sort of same rationale as the point before, making the pulmonary arterial bed the lower pressure system. So if you can lower the pulmonary arterial pressure, hopefully promote blood flow across that pulmonary valve. That will help. That will help hopefully reverse the TET spell and give sustainable, pulmonary blood flow. So that's number 2. Number 3, another basic strategy. This one gets at cardiac output. We all know about cardiac output as it pertains to the LV. We often dismiss the RV, but the components of cardiac output for the poor, underrepresented, and long forgotten RV is the same thing. Cardiac output equals heart rate times stroke volume. Stroke volume is comprised of preload, afterload, and contractility. So we can target preload as a therapy here and give that baby a fluid bolus. Hopefully fill that RV, allow it to have greater preload and ultimately a greater cardiac output, hopefully shunting more of that blood across the pulmonary valve into the pulmonary artery. And so that's number 3 on the list of basic things we can try. And next up, we're trying more intensive therapies, perhaps, that are going to require some closer monitoring with telemetry, perhaps even ICU care. And so what are those options? Morphine classically is something that you can try. Don't necessarily need intensive care for this, but you certainly want to be in a closely monitored setting if you're going to give this child morphine, as of course we know morphine can suppress the respiratory drive and also at times lower blood pressure too if given in too high of doses. So if you give an appropriate dose of morphine, 0.05 mg per kg is a starting dose, 0.1 mg per kg probably is the maximum dose that I'm going to give at one time for these babies. And what that does is it not only relaxes the child, but it acts to relax the RV muscle bundle as well. And so in doing so can help promote pulmonary blood flow. Next up on the list of medical therapies would be Propranolol. Propranolol, as we know, is a beta blocker. It's a negative inotrope, so it's going to help kind of relax the myocardium, relax that RV muscle bundle. It's going to slow the heart rate. Slowing the heart rate in a tachycardic infant will help promote filling time of this sick, stiff, hypertrophied RV. And so it acts sort of in 2 ways, by relaxing that myocardium, relaxing the RV muscle bundle, but also allowing for greater filling time. Same idea as cardiac output that we talked about a moment ago. So propranolol, sort of a twofold mechanism of action there. Something that you would want to keep in your back pocket and probably use once you got the permission of the cardiologist to do so. And then lastly, this one would certainly require intensive care monitoring if you're going to use this medication, and that's phenylephrine, or really any vasopressor that you have at your disposal, but classically phenylephrine is the one that we talk about. There's a handful of vasopressors out there. Phenylephrine is nice because it's alpha specific. It doesn't work on the beta receptors. Just the alpha receptors to promote peripheral vascular resistance and increase and such without the positive inotropy and positive chronotropy that you might see with epi or norepi. So phenylephrine would be an option, but this is the baby that's had a TET spell that's sustained, profound cyanosis associated with it and refractory to the other interventions, and you have this baby en route to ICU for very intensive close monitoring. This would be sort of your last line of therapy. So 6 things here that we mentioned. Again, remember the mechanism of action, and these will make sense, and you can recall these in the moment when you're witnessing a TET spell before your eyes. All right, we've talked all about Tetralogy of Flow, so now we're on to mini talk number 2. This talk's going to cover ductal dependent lesions and dive in just a little bit into indications for atrial septostomy. Let's start with a few cases. Case number 1, a 4-hour-old male born at term, APGARs of 8 and 8, presenting with a cyanotic spell at home during a crying episode. Exam reveals a harsh systolic ejection murmur, heard best over the pulmonic area. Pulse ox on the right hand and the right foot at the time of the event are both 75%. CPAP is placed, FiO2 of 100% is given and the spell does not resolve. What do you think the diagnosis is? This one may sound a little familiar. This could be one of a few different things, but the take-home is that it's severe pulmonary blood flow restriction, inadequate pulmonary blood flow. So one of a few different things, perhaps Tetralogy of Flow with critical pulmonic stenosis or pulmonary atresia, like we talked about just a few minutes ago. It could be pulmonic stenosis with intact ventricular septum, or pulmonic stenosis with a VSD. Could be tricuspid atresia, could be Ebstein's anomaly. You get the point. One of the congenital heart lesions that severely limits pulmonary blood flow. Case number 2, 4-hour-old male, born at term, APGARs of 8 and 9, noted to be cyanotic on routine checkup with mom in the mother and baby postpartum unit. Exam reveals a continuous murmur transmitted to the back. Pulse ox on the right hand reveals a SAT of 75% and 90% saturation on the right foot. CPAP is placed with an FiO2 of 100% and the spell does not resolve. Chest x-ray is obtained and reveals egg on a string appearance with an egg-shaped heart and narrow mediastinum. What do you think the diagnosis is here? This can really only be one thing. There's some clues in the case that give that away. And so you see the right hand and right foot SAT, 75 and 90%. You see the chest x-ray with egg on a string appearance. The only thing here that this could possibly be is transposition of the great arteries. You have this pathognomonic reverse differential cyanosis and chest x-ray finding. And remember this chest x-ray finding because this may show up later on your pediatric board exam. So yeah, TGA, really the only thing that this one could be. Then the final case, 3-day-old female born at term, APGARs of 8 and 9, brought to the ED by parents for lethargy, pale gray discoloration, coolness to the touch. On exam, no murmur is auscultated, and the baby is toxic in appearance with mottled skin and delayed capillary refill. You palpate pulses, and the brachial and femoral pulses are both very weak. The temperature of the baby is 34.5 degrees Celsius. The pulse ox cannot be picked up on the hands or the feet. And what's the diagnosis? Well, here one of the clues is that this baby's 3 days old and is showing up, shocky, very toxic in appearance. The fact that the baby's 3 days old tells you that what maybe has happened is that the ductus has closed and has led you to a state of severely limited systemic circuit blood flow or systemic end organ perfusion. And so this example in particular is hinting at hypoplastic left heart syndrome. Now, if I had given you a case very similar to this and told you that the right upper extremity mean arterial pressure was 60 and the lower extremity mean arterial pressure was 45, the right upper extremity pulse ox was 95, the right lower extremity pulse ox was 80, that would point you probably towards something like coarctation of the aorta. But here this baby's just globally hypoperfused, and this points more towards hypoplastic left heart syndrome. So what's the common thread among these three cases? That is that they're all ductal dependent. There's a pretty simple way to categorize ductal dependent lesions. This was a topic that was pretty confusing to me as a med student and resident, but I learned these three categories during fellowship after seeing a few of these cases, and it's made it much, much more simple. So I want you guys to remember this if you can. Category number 1 would be severely limited pulmonary blood flow or pulmonary blood flow insufficiency, like case number 1. We'll see a more comprehensive list of this on the next slide. Category number 2 would be severely limited systemic blood flow or systemic blood flow insufficiency, like in case number 3. And then finally, the final category, parallel circulations. And really only one example of that, that's transposition of the great arteries, like we talked about in case number 2 on the previous slide. Click on to the next slide, and you'll see a bit more comprehensive of a list of each of these categories and the different lesions under each. The final topic I want to talk to you about in this mini lecture is atrial septostomy and when it's indicated. So let's start with a question. When is an atrial septostomy indicated? Choice A, complete transposition of the great arteries with intact atrial septum. B, hypoplastic left heart with intact atrial septum. C, AV septal defect. And D, Tetralogy of Flow with intact atrial septum. We can narrow this down by the process of elimination here. A complete AV septal defect. We didn't really talk about this, but that consists of a very large atrial septal defect and ventricular septal defect. And there's a few different varieties of this, but in essence, part of the anomaly here is a very large atrial septal defect. So no atrial septostomy would be indicated in that situation. D, Tetralogy of Flow. We've talked about this already. There's a very large VSD in this lesion, and so an atrial septum would not be necessary for intracardiac mixing, intracardiac shunting. So that leaves you with choices A and B, and actually we'll find out in the next two slides these choices are both correct. They both require large ASDs, and so if limited, if restricted, or the atrial septum is intact, an atrial septostomy would be indicated. Let's talk about transposition of the great arteries and why an atrial septal defect is needed, and if that atrial septum has a restrictive defect or the atrial septum is intact, why an atrial septostomy would be indicated. Anytime I think about transposition, I find it to be a pretty confusing lesion because everything's kind of backwards. I have to just trace the pathway of blood flow. So let's do that together briefly. Venous blood, deoxygenated blood returning from the venous system will enter into the right atrium like normal, right atrium to RV, and then RV pumping out to the aorta. And so this deoxygenated blood is pumping out to the body and then returning to the venous system back to the right side of the heart in an endless loop unless there's somewhere for it to mix. Likewise, left side of the heart, the pulmonary veins will bring richly oxygenated blood back to the left atrium to LV, and then LV is pumping out to the pulmonary artery, and then pulmonary artery back to the lungs. Again, an endless cycle. And unless there's somewhere for these two circuits, these two parallel circuits to mix, that will cause significant problems for the child. And so where can blood mix? Obviously the PDA, we've talked about how this is a ductal dependent lesion. What we find though over time is that like in any normal child's physiology, over the first few days to a couple of weeks of life, that pulmonary vascular resistance is going to fall, and the pulmonary system is going to be the lower pressure system as the child continues to age. And so what happens is that blood flow will start to preferentially flow from the aorta across the PDA to the pulmonary artery. And so you're shunting this deoxygenated blood into the pulmonary artery. The pulmonary artery possesses your richly oxygenated blood that you want shunting the opposite direction. And so that's not a sustainable source of mixing for these children. There needs to be a second source of mixing, and that happens at the level of the atrial septum. And so that's why a large atrial septal defect is necessary for these children. If that atrial septum is intact, like I mentioned, or if the atrial septal defect, if the blood flow is restrictive, then an atrial septostomy would be indicated. And I encourage you, if you've never seen this before, go online, go to YouTube, and Google this procedure. It's called the Rashkind procedure, or just atrial septostomy. Watch this. It's a pretty cool cardiac catheterization-based procedure. That's really neat to watch. So let's talk about hypoplastic left heart syndrome and why an atrial septal defect is necessary, and then we can finally wrap this talk up. So hypoplastic left heart syndrome, as the name suggests, the left-sided structures are severely hypoplastic. The classic form of this is mitral atresia, aortic atresia. This is a spectrum, and so some children born with this anomaly will have, some forward flow across the aortic valve, but it's severely limited, and they still have a very hypoplastic arch, and so it's over time going to be insufficient and unsustainable. But let's take the most common version, and that's mitral atresia, aortic atresia, MA, AA, and run through what that would look like in terms of blood flow and why an ASD is necessary. So just like we did before, let's trace the pathway of blood. Deoxygenated blood from the venous system is going to return to the right side of the heart, right atrium to right ventricle to pulmonary artery. Let's ignore the PDA for a moment. So pulmonary artery to the lungs. Then, of course, lungs through the pulmonary veins back to the left side of the heart, the left atrium. And then in the case of mitral atresia, aortic atresia, once this blood hits the mitral valve, which is atretic, it has nowhere to go except backwards into the pulmonary veins and back into the lungs or across an atrial septal defect. And so this richly oxygenated blood, the only path that it can take to get out to the body ultimately is left to right shunting at the level of the atrium. And then once in the right atrium, will mix with the oxygenated blood, pass through the right ventricle, out the pulmonary artery, and then through the PDA, across the PDA to the aorta. And so that you get this mixed blood, approximately 75 to 85% saturated out to the body. And so that's why in this case an atrial septal defect is necessary, and indeed an intact atrial septum is typically incompatible with life. Babies in utero who have hypoplastic left heart and an intact atrial septum typically won't survive to birth. But those babies who are born and have a restricted atrial septal defect, restricted blood flow at the level of the atrial septum, those babies can survive. They just need an atrial septostomy to make that blood flow unrestricted so that they can have adequate mixing. And that's it, guys. We covered everything that I wanted to in these 2 mini talks. We talked about Tetralogy of Flow, of course, the embryologic origins of it, how it manifests on a spectrum of phenotypes clinically, and then what we can do to manage a Tetralogy of Flow spell. And then we pivoted into ductal dependent lesions. We talked about the 3 categories of ductal dependent lesions: insufficient pulmonary blood flow, insufficient systemic blood flow, and parallel circulations. And then we ended finally by talking about indications for atrial septostomy, particularly speaking to transposition of the great arteries and hypoplastic left heart. I hope you enjoyed this talk. Hope you found it informative. Please fill out the surveys if you can. That really helps my research study for me to collect data. If you have any questions about any of the material or anything related to pediatric critical care or congenital heart disease, feel free to reach out. Hope you enjoyed. Thanks.